My guest is Ann Mond Johnson, the CEO of the American Telemedicine Association. We've talked a lot about telemedicine today. In our prep calls, we were trying to define when telemedicine began, like what exactly it meant. I went down the internet rabbit hole and found the University of Nebraska. Some students got together and did a two-way video broadcast in 1969. So that's generally where telemedicine gets credited. But I went even further down to find the concept of remote healthcare being delivered over electronic means, and found this image, which hopefully Caitlin's going to put up. Oh, excellent. From Radio News Magazine, which you can see on the cover was the largest radio magazine of the time. And they had sort of a sci-fi depiction of what remote healthcare might look like delivered through the wireless. Although they did have a picture, a video built into the wireless, so they presaged that as well. But let's just to get started, we've talked a lot about remote healthcare. How do you see and define remote medicine? Because on our call, we talked about it. It's more than just having broadband. How do you define it, and what are the different flavors?
Sure. Well, and first of all, thank you for the opportunity to sit and talk with you and to be with all of you. I appreciate it. The notion of telemedicine, you hear about digital health, digital medicine, telehealth, telemedicine, virtual health, virtual medicine, yada, yada, yada. And I know that there are distinctions to be made that are very well founded, but I have sort of a simple brain. And so when I joined the association at the beginning of 2018, I really focused on the notion of telemedicine writ large, which means synchronous, asynchronous, remote monitoring, AI, which drives the engine underneath a lot of the applications that are out there. And so telemedicine or telehealth, however you phrase it, is really this notion of being able to have technology-enabled communication and services between a provider and another provider, or a provider and a patient, a consumer, when in-person is not feasible or it's frankly not necessary. So it's a pretty broad definition.
I like it. I think we should continue the conversation about equity and access, because it's really one of the primary benefits of telemedicine. And can you just explain a little bit about how your organization is sort of identifying those gaps and highlighting how those solutions can solve some of those problems?
Absolutely. And I really appreciated the comments that were made during the panel before, because what's very clear is that we had a lot of deep-seated problems in the U.S. healthcare system for decades. And the pandemic really brought them to the surface in a very raw way. And so as an association, what we did was create an advisory group that's co-chaired by 3 individuals who are real leaders in healthcare, and put together a series of meetings to create first a framework that looks at how telehealth can be used to eliminate disparities and inequities in healthcare. And the reason why we focused and took that particular point of view is because issues of access, issues of, uneven distribution of high quality medicine, these are problems that have been in place and you cannot solve for them. We cannot create enough clinicians fast enough to take care of our aging and ill population. And so telehealth is the way you address this. It's technology-enabled services, and it's really this idea that you have to reimagine how care is delivered. And so the first output of this advisory group, and it's available on our website, americantelemed.org, is a pyramid. And at the top of the pyramid is connectivity. And we were very deliberate about identifying connectivity at the top. And the reason for that is because it is the most publicly discussed issue. And it's the one that gets the most attention. But we know, and all of us in this room know, that you can solve for connectivity, but you don't solve for inequities and disparities once you sprinkle broadband everywhere. And so there were a number of other factors that we identified in terms of, accessibility, affordability of both the device and the plan. We looked at literacy, both health and digital literacy. We already talked about structural racism. There's the issue of trust, and then bias. And even if you go back to AI and the algorithms, it's very clear, and there's lots of studies that document that the algorithms are based on primarily, for example, white women. And so they are fairly useless and often inaccurate, highly inaccurate, when it comes to diagnosing breast cancer or saying someone's at high risk if they are black or brown. So we were extremely deliberate about this. The next work product that they're doing is really this notion of a heat map. So the reason for that is because you can have parts of the country that have high levels of connectivity. You know, there's a lot out there, but they have poor outcomes. Well, that makes sense. That doesn't make sense. And so what we were trying to do is look at what are the levers that we'll pull in that framework to address that discrepancy. And so an example outside of the inequity universe is skilled nursing facilities. 90% of the skilled nursing facilities in the U.S. have access to broadband. And yet a very small percentage of them, less than half, actually use it. So why is it? Is it literacy? Is it accessibility or affordability? These are the kind of problems on the ground that we have to solve. And so really, that's really what we're talking about. And then finally, we're addressing the notion of how do you make economic sense of solving for disparities and inequities, because you can put it in terms of it's the right thing to do, and it is the right thing to do, but there's a business case for it too. It just makes sense from an economic perspective, so we're working on that as well.
So obviously during the pandemic, basically all rules were off, and the medical industry just had to adapt, as we all did. But a lot of those waivers that were put into place are starting to expire. You've discussed the approaching telehealth cliff. Can you define that term a little bit and then sort of explain how close we are to the edge and what's at stake?
So, as you said, during the public health emergency, we are benefiting from a number of waivers that were put in place both at the federal as well as at the state level. And what was interesting and continues to be interesting is the lack of understanding of what the feds control versus what's controlled at the state level. And I would posit to you that the states actually have a lot more control because they control the standards of practice, the scope of practice, interstate licensure. There are a number of issues that the states play. And so putting pressure on them is really important, and making sure that we don't roll back is a very high priority for us at a policy and advocacy level. From a federal level, keep in mind that a lot of the regulations that govern how we use technology, particularly telehealth, were put in place 14 years before the iPhone was introduced. So what happened with the pandemic is that technology demonstrated what it could do all the time. And it regulations, by being waived, caught up with it. So the cliff refers to the fact that once the public health emergency expires, 150 days after that, we know that unless we act at a regulatory level, that we are not going to enjoy the benefits. They're going to be the same arcane rules that were put in place that will resurface, make no sense. There's a lot in healthcare, but that makes no sense. And, the fact that you have to be in a specific part of the country and stand on your left foot in a particular room in order to get reimbursed or to receive those services, go figure. That's healthcare.
So what can we do about it? Is there an ask for the people in the room? Like, how do we influence those policy decisions before it's too late?
Join. And I think, and it's not necessarily join the ATA, but convene with us, because there was an important article for startups about, should we stay or should we go? And what's really interesting about early stage companies is, again, they don't appreciate how much is at stake with, you see this huge opportunity right now, and in fact, don't understand the fact that a lot is going to go away, or is at risk of going away. And so there is a lot of power in convening and coming around the tent and saying, this needs to change permanently and for the better, because otherwise we're not going to be able to address the issues of access and inequities and disparities across the country.
What's the number one thing you're worried about losing if some of these waivers expire? Like an application, a community that will be left behind? What's like the biggest risk in your mind?
Well, I think, the biggest risk from my perspective is the geographic limitations and the fact that you have to be in a specific place. The other one is because I can name two, because I have the microphone, is the idea of the in-person requirements. So from our perspective, telehealth should not be viewed as a substandard or sidebar issue in medicine. It should be held to the same standards. And so those are the things that we're really worried about losing.
Perfect. Wow. Right
Aren't
at
we
zero.
good?
Right at zero.
Thank you so much.
Thank you so much for traveling.
Thank
This
you.
was great.
Yeah, perfect.